Thank you all for tuning in to this webinar for the Corinne Goldsmith Dickinson Center for Multiple Sclerosis, where we have many of our amazing faculty here to talk about some of the various research that's going on in the field. We do have what we call our flow code, a QR code. If you're inspired by the work you hear, please consider supporting that work with a donation, especially here at the end of the year. But with that, I think we can turn it over to our center director. Dr. Fred Lublin is the Saunders Family Professor of Neurology and, of course, the director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis. Fred, take it away.
Thank you, Tom, and thank you all for being here. This is our annual post-ECTRIMS review for all of you out there. So first, ECTRIMS has become the most important MS meeting of the year. It's an international meeting held usually in Europe, but every third year there's a joint American ECTRIMS meeting that alternates between Europe and North America. This year, ECTRIMS was held in Barcelona. There were over 9,600 in-person attendees, plus people who could attend virtually. It was an interesting meeting, and you'll hear more from my colleagues about what went on there. But in addition, this afternoon, we're going to discuss a bit about what's going on in the field in general as well. And I'll just start out by telling you about a few things that have been on our mind. And one of them is in the area of new therapies. There's a group of agents called the BTK inhibitors, Bruton's tyrosine kinase inhibitors, which have had a successful pivotal trials in progressive disease. There's a couple that have earlier phase studies. We're waiting on the FDA to possibly approve the first of these agents by the end of this month. And I say possibly because the FDA, as you may be aware, has been in a bit of a turmoil for a variety of reasons, including individuals, especially authorities there, leaving. So it's unclear whether that will happen, but hopefully it'll be a Christmas present to the field by approving the first of these agents for progressive disease, probably specifically secondary progressive, but perhaps more broadly. In addition, there's another new area that's getting some play from a number of different companies called CAR-T, which involves eliminating B cells more deeply and thoroughly than what we see with our current B cell inhibitors. And it's a one-time therapy that we're hopeful will have a very durable effect. That is, you get the therapy once, which is very intensive. I'm not going to go into details now, but just understand it's intensive therapy. But then hopefully you're done for a long period of time. We've just completed treating our first patient with this, and we're looking at a few more protocols that will involve that. There are a number of studies going on remyelination and repair. No strong successes just yet, but some interesting approaches, and it's a much more complicated treatment target than, for example, just reducing relapses, but more to come on that. And then there's been strong efforts by our group in terms of lifestyle issues, wellness, and our wellness center has been highly successful and is very busy. Diet studies, which are underway to try and get some real science around what are the best diets for patients with multiple sclerosis. And we don't have the full answer yet, but we're working towards that, along with studies on the microbiome, which deal with the bacteria that live within you and sometimes are good for you and sometimes are bad for you, and how they interact with the immune system and also with illness. So that's a little bit of background of what's going on. Keep in mind, we have some questions that were submitted ahead of time, but there's also a Q&A tab where you can write in questions, and after my colleagues discuss a bit about what's going on, we'll have or should have plenty of time to answer your questions. So with that, I'll turn it over to our Center Medical Director, Dr. Aaron Miller.
Thanks, Fred, and thank you all for joining us today. So there were many, many, many topics discussed at ECTRIMS. I'm going to just highlight a couple of things that were of interest to me in particular. So we've had a paucity of medications approved for any forms of progressive MS. In fact, up till now, we haven't had any drugs approved for what we refer to as secondary progressive MS. Fred already alluded to the fact that we're hoping that a BTK inhibitor will be improved for that. But at the moment, the only approved drug for any form of progressive MS is ocrelizumab or Ocrevus, which is approved for primary progressive MS. Now, that approval was based on a statistically significant but relatively modest uh, benefit and was in a very selective population of patients with primary progressive MS. So, in my own mind, I've always wondered, how good is this medicine, in fact, for this population? So, I was particularly interested in the results of a study called the Oratorio Hand study, which took patients with primary progressive MS, but who were more advanced in their disease process. Many of them had significant limitations in walking and would not have qualified for the previous study. And the study used a composite endpoint rather than the traditional EDSS, which is a scale that's primarily driven in patients who have some disability by walking ability. So the Oratorio Hand study showed a significant benefit for Ocrevus in that population, excuse me, which to me is very important in sort of ratifying the conclusion that came out of the previous Oratorio study. So that was a little bit reassuring. Still, we need much better and more medicines. The other subject that was widely discussed, which is of great interest to me, relates to how we use medications. We're fortunate that we have many, many medications now for relapsing forms of MS. And among the most widely used of those are the B cell depleters, which include Ocrevus or ocrelizumab, Kesimpta or ofatumumab, and Briumvi, ublituximab. But these drugs carry risks. And so there's been a lot of attention now to how can we reduce the risks of these drugs. The major risk over time is an increasing risk of infections as time goes on. And some of those infections can be serious. So there's a lot of interest in the field now as to can we use these drugs in better ways or different ways. And so one study that was presented looked at an older drug called rituximab, which also gets rid of B cells, but is not FDA approved in the US, but is widely used, for example, in Scandinavia. And in one study, that drug, rather than being administered every 6 months, as is the traditional way to use that drug, was given after the first year every 12 months. So that would reduce one's exposure to that drug. There was a lot of talk about studies that are going on to take patients who are on these B cell depleters and de-escalate after a period of time to alternative therapies or even to stop the medicines. And here at the Corinne Goldsmith Dickinson Center, we were involved in one such study called the AMSO5 study, which is orchestrated by a neuroimmunologist from the University of Pennsylvania, in which patients who are newly starting on ocrelizumab, rather than continuing the medication through the full 4 years of the study, are taken off the medicine after 2 years. And we'll see, at least from that study, which still has about 4 to 5 years to go, at least we'll know whether we can at least temporarily halt that medication. So these are important, and there are many, many other studies planned over the next few years. And I suspect that over the next 5 to 10 years, we'll be using these medications quite differently. So those were some of the highlights that were of interest to me. And at this point, I'll turn this over to my colleague and one of our stellar neuropsychologists, Dr. Sarah Levy.
Thank you, Aaron. Hello. So at ECTRIMS this year, Dr. Maria Pia Amato who's a professor at the University of Florence, gave the plenary talk, which is the keynote that opens the entire conference. And the title was Cognition in MS, Progress and Perspectives. And the fact that cognition was chosen as this year's plenary, I think really highlights how cognitive health has become a top priority in MS research and clinical care. Dr. Amato emphasized that cognitive symptoms such as memory, concentration, and word-finding difficulties are common in MS and can significantly impact daily life. These challenges can occur across all types of MS, relapsing remitting, progressive forms, and even in the very early stages before diagnosis even. She also highlighted the role of cognitive reserve, so how mentally stimulating activities like reading and hobbies and puzzles and social interaction may help to protect brain function in people with MS. A key takeaway from the plenary is the importance of early and routine cognitive screening. At our MS Center, I help lead the comprehensive assessment clinic, where our neuropsychologists provide evaluations that are short enough to be manageable, but also thorough enough to detect subtle cognitive changes, track them over time, and offer strategies and support, ideally before cognitive difficulties may start to significantly impact daily life. And then building on this focus, I had the opportunity to present my research at ECTRIMS. So I examined cognitive profiles in older adults with MS, so older than 65, compared to people with Alzheimer's disease. And one of our findings was that the kind of language and memory difficulties in older adults with MS are different than what we see in Alzheimer's disease. And so identifying some of these key differences can help us more accurately distinguish between what might be MS-related cognitive changes from other conditions. And I think that paves the way for more accurate diagnoses and treatment plans. And I think overall, essentially, the theme from the plenary and other cognitive research I saw at ECTRIMS was that the field is really shifting from reacting to cognitive issues to actively trying to prevent them and protect brain health. So this includes early screening, building cognitive reserve, and supporting brain healthy lifestyle strategies as part of everyone's routine MS care. And so at our MS Center, we're really invested in helping you preserve your cognitive health, safeguard your quality of life, and continue living independently while staying engaged in what matters most to you. We have our wonderful wellness program that has nurse practitioners, occupational therapists, physical therapists, social workers, psychologists. And the idea is really to protect cognitive health and what matters, again, what matters most to you. So with that, I'm very pleased to introduce my colleague, Dr. Sylvia Kleinova, an associate professor of neurology and an MS neurologist who provides care for many of the patients at our center.
Thank you, Sarah. Sarah is my dear collaborator on a research project that we presented at ECTRIMS, and I will talk about it a little bit later. But first of all, one of my personal highlights from ECTRIMS of this year, but also sort of through the year, is the shift that we're seeing in MS field in regarding how we're looking at MS biology and phenotypes. So the first initial disease course was described by no one other but our own Dr. Lublin. And when I joined as a fellow in 2012, he went through another redefining MS phenotypes. And it is interesting for me as my career and path through MS went on, how the field is now shifting, looking at the MS not as a sequential disease, but as a one disease with dual biology, relapsing inflammatory disease and progressive degenerative disease. And I think it's a quite big shift that poses multiple challenges. We have to start talking to our patients earlier about a concept of progression. We as healthcare providers need to decide how we're going to define a progression in multiple sclerosis, how we're going to measure and what all constitutes a progression. But I also think that it opens possibility for focusing more on symptoms that maybe we neglected or maybe we were not looking at from the very beginning. So cognition, as Dr. Levy mentioned, fatigue, pain, changes in bowel and bladder, and going away from sort of boxes or different phenotypes might allow us to do more personalized care and describing a disease course for individual patients with focusing on their individual needs and their individual disease. We are entering era of maybe new therapeutics. Dr. Lublin mentioned BTK inhibitors. Some of them hopefully coming later on next year might have dual impact on relapsing and progressing disease if they are shown to be successful. And I think that that might move us forward to maybe having disease agents that will affect that dual biology that we're looking in multiple sclerosis from the very beginning. As I said, I would like to mention two research projects that my collaborators and I presented at ECTRIMS, and both of them were we were able to successfully execute because of this great research project that we had at our center. So the first project was I collaborated with Dr. Levy and my colleagues from the comprehensive neuropsych clinic, where patients undergo comprehensive assessment every year, and this clinic generates an amazing amount of very interesting data that we were able to analyze. So our project focused on looking at socioeconomic determinants of health and other modifiable lifestyle factors as a possible explanation of the increased disease severity that we see in underrepresented minorities with multiple sclerosis, specifically Black patients with MS. As I said, we analyzed data from the comprehensive neuropsychology clinic. Patients undergo this assessment every year, and it's a part of our comprehensive care. The project generated few presentations. We presented at national and international conferences. Dr. Levy also had a platform presentation at CMSC meeting, and we found some very interesting results when it comes to socioeconomic factors and adherence to Mediterranean-style diet, mediating disparities that we saw in disease outcomes. And we think that this opens possibility for addressing disparities, having modifiable factors that can help us guide targeted interventions for patients that would benefit the best. The second project we presented was, again, analysis of data of a large NIH-funded study. The Dr. Lublin was one of the co-PIs, and the study looked at disease severity in Black and white persons with MS in comparison using different clinical and radiological measures. We actually looked at personality profiles of our patients and looked at their resilience in a longitudinal way, which is not something that has been done before. And we found or identified some of the personality traits that can help improve resilience of our patients. So again, this poses some modifiable or interventionable point of care where we can improve resilience in our patients with MS. And with that, I'm going to turn it over to my colleague, Dr. Satya Narayan, one of our newer faculty members, and she will tell you about her highlights from ECTRIMS.
Thank you so much. So I wanted to spend some time today talking a little bit about the advances in biomarker testing in MS. This is a really rapidly evolving area of research, so just wanted to include a few highlights from the conference as well as this year. From a diagnostic end, one of the things that was discussed at our meeting this past year was a recap of the recently published 2025 McDonald criteria that was updated for the diagnosis of MS. And this new set of criteria incorporates the use of a different MS diagnostic in the spinal fluid. It's called the kappa-free light chain index. It is really similar to our current gold standard in MS spinal fluid diagnostics in that it compares inflammation in the spinal fluid to the blood. But this test is actually a little bit more quantitative than our current gold standard. And eventually down the road, it could replace some of our other testing as a screening test. But right now, this is in addition to our current testing, but it is something we've already included in our workflow at our center here. Next, ECTRIMS focused a lot on if testing could really help us in treatment monitoring. And so far, a lot of the ways that you've seen, physicians at this center and other centers around the world defining success with MS therapies have been no new symptoms, stability in your neurological exam, and stability in your MRI. But a lot of institutions have actually started to incorporate biomarker testing into that assessment of stability, including ours. And one of the main tests that's being incorporated right now is something called neurofilament light chain. This is a blood test that can detect levels of nerve breakdown in the body. And the idea here is that it's possible we can detect subtle MS inflammation that's causing small amounts of nerve injury. There are a lot of important drawbacks to this test. You need to correct for age, BMI. There's a lot of research that still needs to be done in understanding the pitfalls of this test when you use it for treatment monitoring. So this is not an end-all be-all, but it is sort of a new part of the puzzle you will see us using clinically. Lastly, is prognostication of disability worsening. And one of the things you've heard about today is a move in general in the field to really trying to conceptualize MS disease processes on a biologic level. And I think biomarker testing is a really tactile connection to understanding these different biologies in real time. So at this meeting, we heard from our colleagues in Switzerland, who have been one of the leading sites globally for biomarker innovation in MS. And this year, they showed data from about 1,700 patients, primarily relapsing remitting MS patients. And they saw that high readings of neurofilament light chain, the marker that I just mentioned regarding nerve injury, was associated with an increased risk of progression independent of relapse over the following 7 years. Another study in that same group of patients looked at the trajectory of blood test readings. They focused on a slightly different test. It looked at a marker of glial cell injury, which are a key companion cell to neurons. This marker is called GFAP, and they actually showed that for folks who had persistently high or increasing levels of this test over time, that was also associated with a higher risk of progression. We've actually looked at these biomarkers in our Sinai cohorts as well. We've presented similar data a couple of years ago at an international meeting showing that association we saw in our patients with an elevated level of neurofilament light chain and an increased risk of progression, even in early MS. And right now, we're actually in the process of processing data on some of the longer follow-up of that study, again, trying to look at this trajectory over time. And hopefully next year, we'll have some more results to share with you and our scientific community. And then lastly, looking beyond any one particular blood test, I think one of the most exciting parts about this field right now is the predictive power that we might gain in combining biomarkers. A really interesting presentation this year at the conference showed a group from Germany that looked at spinal fluid testing. They didn't see any one particular protein having a huge utility in predicting patients who progressed. But if they combined a group of about 13 different proteins from the spinal fluid, they had about an 86% accuracy in predicting this. All of this to say, biomarkers and prognostication are still in the research phase. They're not quite yet prime time. But a lot of this comes down to understanding that unique biology within each person's MS, knowing you can get disability worsening through different mechanisms in MS. And then understanding what type of biomarker, the trajectory of that marker, and perhaps the power of multiple markers, I think could really change our ability to individually prognosticate in the future.
Thank you, Samita. Tom, you want to pick up?
Yeah, Fred, I guess if you have just a reminder to everybody that there is that Q&A function if there are any of the projects or updates that you heard about from the faculty that you have further questions on. Otherwise, maybe, Fred, we can start with some of the audience questions we received ahead of time.
And I'm not seeing any questions coming in from the Q&A, so please feel free to put them in and maybe AV make sure that I'm actually able to see them. Okay, so one of the common threads of the questions that we had ahead of time was when to stop medication. Various medications, including things like ocrelizumab, Ocrevus, that Aaron Miller had talked about. So, Aaron, why don't you talk about stopping medication?
Okay, I'm happy to talk about that because it's a subject of great interest to me. And one of the talks at ECTRIMS that I heard, which was a review sort of this subject, used a very nice graph. So I want you to look at my hands, and if you can think of my of these fingers as risk, and the lower fingers as benefit. There's a crossing point. With it depends on your drugs, but in particular with B cell depleters, and age is along the lower axis. So if you can think of a young person with a B cell depleting drug, for example, has a very high likelihood of benefit and a rather low risk. As a person gets older, and maybe that crossing point of the X maybe arbitrarily is around 50 years of age. When you get above that age, your risk is going to go up and your potential benefit from these drugs is going to go down. And we need to find that crossing point for individual patients. And it's going to be different for individual patients and individual drugs. It's going to be influenced by a person's age, but also by their comorbidities and by the nature of their MS. So I think, as I said in my earlier comments, there's going to be a lot of focus over the next few years as to how can we decrease the risk while maintaining optimal benefit for a patient with a particular treatment. And that might mean stopping drugs at some point. It might be de-escalating from a drug that has a higher risk to a drug that has lower risk. A few years ago, we were very active participants in a trial called DISCO MS, in which we took people ages 55 and older who had been very stable with their MS, no attacks for at least 5 years, no new lesions on their MRI scans for at least 3 years, and continually on disease-modifying therapy for 5 years. And we took half of them off their medicines and left the other half off. And although the trial did not prove that it was not inferior to discontinue medicine, in reality, almost nobody in that trial had clinical relapses, either having been discontinued or not discontinued. The people that were discontinued, a few more had 1 or 2 small MRI lesions, but in general continued to do very well. One drawback of that study was that most of the patients in the study had been on the older injectable drugs. So we need more data about people discontinuing our high efficacy therapies like the B cell depleters and Tysabri, as well as some of the more effective oral agents. But I think we're seeing more and more attention being paid to that. And I talked about the one study we're doing that limits the use of a B cell depleter to 2 years rather than 4 years. So we're going to start to see data emerging. And I have no doubt in my mind that there are many patients who can safely discontinue drugs. For example, from the DISCO trial, which we started to enroll around 2017, 2018. So I have many patients from that trial who are now 7 and 8 years off medication and doing extremely well.
Well, we have you, Aaron. And there was a question about the new Ocrevus treatment, and I think that relates to the sub-Q. You want to just say something about that?
Yeah, so there is a subcutaneous that is it's not really an injection, it's sort of an infusion under the skin. It takes about 20 minutes. We have no personal experience yet with this formulation at the center. It's a little bit hard to see a great advantage to that treatment. It is, of course, shorter than the traditional Ocrevus infusion, but much of the time involved in an infusion is the getting there and the getting out of there. And these subcutaneous administrations still have to be done in an infusion center. So if and when we get that drug on formulary here, we'll find out if it's something that patients are that it appeals to patients. But as I've talked to colleagues around around the US, I haven't found a lot of enthusiasm for that formulation yet. I don't know if any of my colleagues have had a different experience.
Not much enthusiasm as yet here. We have a couple questions about treatment in older age group. And I noticed that the oratorio hand study that you mentioned used individuals up to age 65 as opposed to their original study, which was 55. And I think that the safety was okay, even going up to that group. But it's been an issue that we've been thinking about. Samita, you want to say a little bit about dealing with older age group?
Sure. I think that, we've thought a little bit about the risks and the benefits, I think, with regards to therapy in particular. And, we just heard a little bit about obviously thinking about de-escalating therapies and or discontinuing therapies in patients who have older age groups. I think one of the things that we didn't mention from that DISCOM study is a significantly improved quality of life that people perceived coming off of therapy, and it's not something that we discount. I think also, one of the things that we're looking at from the biology standpoint of MS is recognizing that we have both the biology of MS as that age changes, but we also have the biology of aging concurrently that's happening in a lot of individuals. And so one of the things that I think we're thinking about a lot right now is starting to understand how that biology of aging might be accelerated differently in MS. From the biomarker end, kind of how we can use biomarkers to sort of better understand that, assess that. And then also, I think comprehensively thinking about it from a clinical end, trying to see how we can kind of best support people who are aging through MS, regardless of what type of MS they may have, to really sort of provide a holistic kind of clinical approach to caring for patients.
Good. Thank you for that. And then I have a question here. I'm going to throw this one out to Sarah. So what are the key drivers of preserving cognition? What programs are in place at our center for preserving cognition?
This is a great question. So I think very importantly, we think that modifiable lifestyle factors play a huge role in preserving our cognitive health, our brain health. So some of the strategies we talk about are a brain healthy diet, such as the Mediterranean style diet. This is a diet that's rich in vegetables, whole grains, as well as healthy fats, especially olive oil and nuts and fish. This keeps our brain as healthy as possible. Regular physical activity like cardio and strength training is really important. When we're doing cardio and pumping our blood up to our brain, the part of the brain that seems to benefit a lot is the hippocampus, which is important for memory function. And then to that note, also healthy sleep habits, which are also really important given the link between sleep and memory function. Managing other health conditions totally outside of MS, right? Like high blood pressure, your heart health, diabetes, that's incredibly important for your brain. And then, of course, staying socially connected, engaging in mentally stimulating and intellectually stimulating activities, again, like reading, puzzles, learning new skills, are also good for your brain. And at our wellness program, the experts guide resources and supports in terms of how to incorporate these habits into daily life. We even have a nutritionist that helps with adhering to a Mediterranean style diet. So if you're interested in the wellness program, please ask your neurologist or anyone at the MS Center about more information about this.
Thanks, Sarah. I have a question about Ocrevus and serious infections. So, Ocrevus is one of our most successful therapies for reducing relapses, and it has modest effects on progressive disease where we don't have anything else at the moment. There are uncommon but serious infections that can occur that appear to be related to time on drug, may be related, maybe not, to reduction in a level of the antibodies in the bloodstream, what are called immunoglobulins. But it relates to what Aaron Miller was discussing about our thinking about delaying injections, stopping or de-escalating to other drugs. And this is an area that we're thinking about and trying to draw some conclusions about. We don't yet have all the data we need to have to make a reasonable conclusions about that. Here's one just to follow up, Aaron. For a patient that does discontinue a therapy that subsequently had a relapse, would the assumption be that restarting the therapy, for example, Ocrevus, would return to stability?
I think the assumption would be that that's the case. We don't really have data to prove that, but I don't think biologically there's any reason to believe that a person who was continuing to have inflammatory activity would not respond to going back on a highly effective therapy.
And here's a question for you, Sylvia. It's a very straightforward one. Any talk about a cure?
Oh, okay. So, well, yes. I mean, no. Well, we always talk about the cure, but I think, as long as we as much as we study MS, we're finding that MS is a very, very complex disease, and might be, or most likely is very heterogeneous for individual patients. So I am not sure that if there is going to be a cure, and I would love for it to be in my professional lifetime. It's probably not going to be a cure for one for all. I think we might be able to identify patients with different biologies or predominant biologies at different courses of the disease, and what part of the immune system might be predominantly driving the multiple sclerosis. And maybe we'll find different approaches for different group of patients. But I don't think that there's going to be one cure for all patients with multiple sclerosis.
There's some hope amongst our colleagues that are more impressed with the Epstein-Barr virus data than perhaps I am, with the thought that if one can develop a vaccine for Epstein-Barr before MS ever starts, that may limit the development of multiple sclerosis. It's an interesting idea. We're not yet there with an Epstein-Barr virus vaccine, but I think they're getting close with some. So it might be interesting in terms of never getting it started. There's even some who think that treating Epstein-Barr during the course of the disease may be of value. Again, I'm not a proponent of that particular idea, but it'll be nice to see the science behind it. There's a couple of questions that are rather personal to the individual, and we're not going to be able to answer those. I think you need to take those up with your provider, because they're specific to a given individual. Here's an interesting one, and I don't know who wants to take this one, but well, BTK as combined with CAR T, any ongoing trials? Well, maybe I'll take that. And so and there's also a question of whether the BTKs can be combined with any of the ongoing therapies like B-cell inhibitors. I'm not sure. The concern in my mind would be more severe immunosuppression. And also, the idea of the BTKs is they have a deeper tissue penetration to remove B cells. So I would think of them more as sequential, taking people going from an anti-CD20 antibody like Ocrevus and then maybe going on to a BTK. Anyone have any other thoughts about that?
I would just chime in that I think it's important for our listeners to understand that there are many, many questions that we could come up with about combining therapies, trialing therapies, but people have to understand that there are tremendous barriers to doing clinical trials, including a gigantic financial barrier. So somebody has to pay for a trial. A phase 3 trial of a new medication is about $100 million at the moment. And so somebody with pretty large pockets, pretty deep pockets, has to be willing to fit that bill. And that's usually a commercial pharmaceutical company. The government doesn't pay for those kinds of trials. The National MS Society in no way can pay for studies like that. So we can think of all the things we want to try, but there has to be a certain practicality to the design of the trial You don't want to do a trial that can't answer a question or provide useful information. And so you have to be practical. And, insurance companies don't like to pay for even one drug, let alone two drugs or two treatments. So these are unfortunate barriers to getting the important answers that you and we would like to have.
Right. And so, because I don't want to leave people with the idea that they have to get off their Ocrevus. What I'm trying to get across is that we need to think about it over the long term. But right now, we are using it long term because it works so well. But we are trying to think of strategies to do just what Aaron was showing with you with his hand metaphor. Make sure we can balance the benefit with the risks, and we don't yet have the data for that. Here is a question for Sylvia. What percentage of people living with MS have other autoimmune conditions? And if so, is there a higher incidence of specific types? And does gut health impact all types of autoimmune disorders?
Yes and yes and yes. So yes, we do see higher percentage of autoimmune diseases in multiple sclerosis patients. There's different percentages that different research found. I think the lowest estimate was about 8%. Then there was one said about 13%. I think the highest was about 30%, 30. As far as which autoimmune conditions we see, the most commonly we see autoimmune thyroiditis. Then we see psoriasis. We also see inflammatory bowel disease. We see different rheumatological conditions. And this all is caused by this genetic predisposition of patients with multiple sclerosis, having also genetic predisposition towards autoimmune conditions in general. This is determined by the presence of very small changes in DNA, in genome. These are not big genes that one passes to their offspring. They are very small changes, and they can increase risk for autoimmune conditions or multiple sclerosis. And then we see sort of accumulating sometimes of more autoimmune conditions in individual with multiple sclerosis. Gut was a question about gut microbiome causing other autoimmune conditions. Yes, there has been loads of research going into a gut microbiome. You can think about your gut as your largest immune organ. It hosts the largest amount of immune cells, and the thought is that while they're in the gut, they might get exposed to different parts of microbiome, recognize them as a antigenic target, and then based on something we call molecular mimicry or false recognition of that target somewhere in the organism, they can cause autoimmune diseases. There were a few diseases that were studied. Multiple sclerosis was one of them. Then I believe it was rheumatoid arthritis. Obviously, inflammatory bowel disease like Crohn's disease was also studied. We have a very large national consortium that studies patients with multiple sclerosis and other demyelinating diseases and their gut microbiome in order to identify unique microbiome in patients with demyelinating diseases and maybe then from there to move towards therapeutics. So changing or affecting a gut microbiome in those patients.
Great. And Samita, I'm going to throw this one. It's kind of a personal question, but I'm going to make it more general. And that is, the issue is, are there any new medications for relapsing MS that don't have a PML risk? Seems to this individual all do. And what does a person with a high titer do? What's their risk when we think about putting them on a medication?
Yeah, I think that's a great question. And I think it's one that a lot of people are worried about, especially when you've had a conversation where you've talked a lot about Tysabri and maybe you're not going with Tysabri, but there is still that titer in the back of your mind. I think that in general, we tend to think that the risk with any of our other currently approved FDA therapies for MS is really pretty low. I think that the most recent count, for example, with Ocrevus, which has over 420,000 people treated, there have been no more than 18 cases ever reported. So the chances being less than 0.004%, a very, very, very low percentage. And I think that, this isn't to say that it's not possible. There certainly have been other PML cases, very rarely reported with many different kinds of MS therapies. Oftentimes we are worried and we are looking for people who may have some other issue with their immune system. So, if we're not talking about Tysabri and we're not looking at necessarily that JC positive titer, we might be monitoring from the biomarker end, we might be looking at the counts of your white blood cells over time. And one of the things that might, tip us off as physicians to wondering about your risk with another kind of therapy is whether or not you have any other number, like numerical abnormality in those white cells or any other signs of dysfunction in your white cells. And I think those would be things that would potentially help stratify and figure out if you'd have a higher risk with that.
Well, I have you. There's a question here of incorporating biomarkers into trials for drug holiday approaches.
Oh, yeah, that's a really great question. So as for specifically regarding drug holidays, meaning to come off and then to come back on, I don't know if there's a specific trial that's ongoing that's doing that, but there are a lot of trials right now that are ongoing that are either, as we've alluded to, either testing a therapy for maybe 2 years, like Ocrevus at one time, which is part of a trial we're involved in right now, or there's a trial currently ongoing that's recruiting in Europe where they're taking people who are coming down from a high efficacy therapy like Ocrevus to something that might be more moderate to low efficacy on average. And I think that in terms of using the biomarkers, right now, most of these biomarkers are not necessarily the primary outcome. However, I think they are getting built in to becoming a really key secondary outcome in a lot of the trials that we're looking at. We have been incorporating these biomarkers into pretty much all of the other kind of relapsing remitting MS trial data that you're going to see. You're also probably going to see it as an exploratory or a secondary outcome in a lot of our other secondary progressive trials too. And that's where, a lot of this came from. We oftentimes did see a reduction in, the most common one that's used is neurofilament light. We saw a reduction in that with most of our therapies that are currently available for relapsing remitting MS. So they're definitely looking at it. They're definitely using it. I think one thing that is a little unique about one of the trials that's currently being run by one of our colleagues out of our center here that's looking at the Mediterranean diet is that trial actually is trying to look at neurofilament light as a primary outcome. And I think that is, a really interesting approach to start to look at quantifying nerve damage over time and seeing how we can relate other things to that.
Okay. For Sylvia, what is the incidence of liver issues or cancer? And they didn't specify which agent, but just in general.
It is different for every medication that we have. I understand it's in regards to treatment agents, I would assume. So there are different medications. Some of them have a higher risk of liver injury than the others. Theoretically, there's always a chance for liver injury, especially in the beginning of the treatment. And that's why we usually monitor liver function tests in patients that we start on treatment. There are a few agents that may have a potential higher risk of liver injury. And then there's a recommended more frequent monitoring. As far as cancer, I think every trial for any MS therapeutics had few cancers, either in an active arm or control arm. As far as we know, those percentages were no different than percentage of the given cancer in a general population. So I know people heard about anti-CD20 because it has to be mentioned in prescribing information, but it is important to say that FDA does not mandate any extensive cancer screening for patients on MS therapies. So we institute screening for cancer as is appropriate for given age and individual risk of cancers. But if you look through the results of trials, there were cancers reported in pretty much any or every MS trial.
Okay, thank you. Aaron, a question here about the percentage conversion rate from radiologic isolated syndrome to MS.
So the radiologically isolated syndrome, for our audience members who might not be familiar with that term, refers to patients in whom MS is not suspected, but they get imaged with a brain MRI for other reasons. In the US, it's most often for headaches or for minor head trauma. And then the MRI turns out to look like the MRI of somebody with MS. So those people traditionally have been called radiologically isolated syndrome. If you look at all comers with that moniker, over 5 years, about a third of them are going to develop clinical symptoms that will enable them to be called MS. And in 10 years, about half of them will have clinical symptoms. And usually it's a clinical relapse. A very tiny percent will develop progressive MS. But we have a number of factors now that we can identify which increase or decrease the likelihood of that conversion to clinical episodes. The other thing that Dr. Sadeh and Ryan earlier alluded to, what she called the 2025 McDonald criteria, which everybody else will call the 2024 McDonald criteria. But in the 2024 McDonald criteria, a lot of patients that we previously called radiologically isolated syndrome now meet the criteria that we use to call them MS, because we've known that many of them actually have MS and behave like MS. But some of these people who have very low numbers of these risk factors probably don't warrant, in my opinion, going on therapy initially.
Okay, and there was a number of questions that came in relevant to an older age group, 50s, 60s, 70s, and it's good to bring it up. It's an important issue, and there's a number of reasons to think about that. A, we're seeing MS in an older age group than we used to, and it's become a new area of research, actually, of looking at MS in older individuals, because there is a various phenomena around how your immune system changes as you get older. But it's not just the MS that we have to deal with when individuals are older, but everything else that life throws at you when you're in 50s, 60s, 70s. And so we spend a lot of time with individuals looking and seeing how the different aspects of aging have an effect on whatever the MS had done to you, perhaps at an earlier age. And so we want to make sure that people are getting exercise. And you heard about diet, cardiovascular health, because comorbidities occur on top of whatever the MS has done to you and whatever limitation to your reserve it's done. So there's a lot of interest in this area and looking at how the individuals in an older age group do. And because we have more individuals getting into older age, because we've been so successful at treating at least many forms of the illness, and hopefully moving forward to better treatments for progressive disease. So as I said a little bit earlier, those of you who sent in more specific questions to your own health, I can't really get into those. The individual who asked about birefringent microscopy, I'm afraid I don't have the expertise to answer that question. But I thank you very much for the questions that you've sent in, both before and while we were having this session today. I hope I got to them and got to your questions. And I'm really delighted that everyone could have joined us. And I thank very much my colleagues for their sage advice and comments. And I'll turn it over to you, Tom.
Thank you so much, Dr. Lublin, and thank you to all the faculty for taking this time to present this really fantastic information to our community. And of course, you know, I wouldn't be doing my job if I didn't mention that so much of what goes on in the MS Center is supported by philanthropy. All aspects of the mission, all the research that you heard about, a great deal of the clinical care is underwritten by philanthropy. And of course, the education mission, where we're constantly training new residents and fellows in this field of MS. So if you are inspired to give back and support the work of the MS Center, we have the QR code on the screen right now. But otherwise, thank you all so much and have a wonderful holiday season. Thank you for joining.